And our talk today about KPIs in colonoscopy, how to fulfill. Colonoscopy is a safe and effective tool, but operator dependent. Colonoscopy is one of the most common medical procedures. Over 19 million performed annually in the United States. Currently, the large majority of CRC screening is performed with colonoscopy, which is estimated to reduce the CRC incidence and mortality. Despite common use of the general acceptance as a gold standard for CRC screening, colonoscopy still has variable quality. And to reach quality, we need to pre-procedure, intra-procedure, and post-procedure quality indicators. And we will begin with pre-procedure indicators. First, you must have a time with your patient for three important points for documentation of the indication for colonoscopy: informed consent, adherence to the appropriate surveillance interval. In most clinical settings, these process measures are documented in the pre-procedure note or the electronic health record. However, directing providers to include this information in the endoscopy report can facilitate routine collection of these data, and this increases the quality which we are achieved. Intra-procedure, according to the American Society of Gastroenterology and the American College of Gastroenterology, we need to encourage detailed mucosal evaluation during colonoscopy, and we need to details in this point. And the first point, bowel preparation quality. Bowel preparation of at least adequate quality to be achieved in 90% of the patient and aspiration to 95%. We have validated national bowel preparation scale should be developed. And with this bowel preparation or inadequate bowel preparation limit visualization of the colon, like this picture in the left, and we can also lead to repeated procedure, increase the healthcare cost, and further demand on patient with endoscopy unit. Validated scales allow endoscopists to perform standardized scoring of bowel preparation quality at the time of the procedure, and the Boston bowel preparation scale is one of the most appropriate one we can use. Adequate preparation is defined by the ability to detect polyps smaller than up to 5 millimeters, more than 95% of colonoscopists, and for all indications, and more than 90% of screening colonoscopists should be scored adequate or better to meet, according to the American Society of Gastroenterology. When poor bowel preparation precludes the examination, colonoscopy is appropriately to aborted, and you can stop the examination and the patient asked to return again. This is the Boston bowel preparation scale. From inadequate, we can give 0, poor 1, good 2, and excellent 3 for the left colon, transverse colon, and the right colon. The second point about the cecal intubation rate, minimal unadjusted cecal intubation in 90%. The colonoscopist should aspire to achieve 95% of unadjusted cecal intubation. And also there is a very, very important point about the photographic documentation of cecal intubation should be obtained with image taken for clear cecal landmark or of terminal ileum. High cecal intubation rate are associated with high adenoma detection rate and low incidence of interval cancers, and in particular protection of right-sided CRC. The performance target is more than 90% for all colonoscopists and 95% of screening. There are also patient factors that may hinder the ability to reach the cecum, including the low body mass index, history of hysterectomy, bowel preparation quality, anatomy, inflammation, and obstruction. One of the most important points in KPIs is the withdrawal time, and we have many literature about this point. Not less than 60 minutes minus to the time to perform bilobectomy or other maneuvers associated with higher detection of neoplastic lesions during the colonoscopy in patients with intact colons and reduce the risk of interval cancers. The second point, adenoma detection rate, which is very important nowadays. We have CRC screening program in Egypt. Minimal adenoma detection rate should be less than 50%. Aspiration adenoma detection rate should be 90%. Where polyp detection rate can be shown to be accurate, it may be used to a marker as adenoma detection rate through the examination of colonic mucosa is crucial to maximize the effectiveness of colonoscopy as a diagnostic test, and the lower adenoma detection rate associated with higher rate of interval of cancers. Colonoscopists with adenoma detection rate less than 20% had a hazard ratio for interval cancer that was 10 times higher than colonoscopists with adenoma detection rate more than 20%. Rectal examination and rectal rectal examination or omission should be recorded in 100%. Rectal retroflexion should be performed in 90% of cases, and digital rectal examination has been recommended as a standard part of endoscopic examination of the lower gastrointestinal tract, with the aim of preparing the anal canal for the insertion of the scope and to examine the anal canal and the lower rectum for pathology. A comparison between the digital rectal examination and the retroflexion shows that the digital rectal examination was sensitive for detection of the abnormalities in the lower rectum and the upper anal canal that were subsequently demonstrated on retroflexion of the endoscope. The second point, polyp retrieval. Polyps should be retrieved with histological assessment in 90% of the cases following successful polyp removal. It is important to retrieve it for histological assessment. This is important to establish the histological nature of the polyp, to determine the surveillance interval, and to establish the presence of advanced features such as high-grade dysplasia, villus component, or cancer. Polyps less than 1 centimeter are less likely to contain these features. However, retrieval is still important to determine whether there are adenomatous features that determine the need for surveillance or not. Polyp retrieval is also considered a reflection of the technical skill of the colonoscopist. Can I have a biopsy for or diagnostic biopsies for unexplained diarrhea or not? The guidelines say that as an aspiration 100% of the patient with unexplained diarrhea undergoing colonoscopy to have right and left-sided colonic biopsies, and macroscopically normal examination doesn't exclude all causes of unexplained diarrhea, with the most common diagnosis being microscopic colitis. Microscopic colitis can be patchy, and biopsies from both the right and the transverse are required for diagnosis, a practice reinforced by the American Society for Gastroenterology Endoscopy. This is all points we much fulfill intra-procedure, and most procedure will also have many points. One of the most serious complications is the perforation. Perforation is a rare but serious complications of colonoscopy and should occur in less than 0.2% of all colonoscopists and 0.1% of screening colonoscopists. And the overall colonoscopic perforation rate is influenced by the proportion of diagnostic to the therapeutic procedure performed. For the diagnostic colonoscopy perforation rates from 0 to 0.2 are reported, and the two main risk factors post-polypectomy perforations are according to the site and the location. This is the guidelines again about the stratification of the perforation severity from major, which we can deal with either with managed conservative or endoscopic or surgery, or which is fetal up to death. Bleeding, the risk post-procedure or bleeding post-colonoscopy is very small with diagnostic colonoscopy, but increase markedly when polypectomy is performed. The two main risk factors are the size and the proximal cecal location of the polyp. Other reported risk factors include the comorbid conditions like cardiovascular or chronic renal disease, age, anticoagulant use, and endoscopist experience. And this is the guidelines again according to the American Society of Gastroenterology, stratification of bleeding severity, which is minor or intermediate with drop of hemoglobin more than 2 grams, major, which can deal with surgery, and also fetal. Other stratification of other adverse event which can happen with each other, with all of them, with like hypoxia, hypotension during anesthesia. And also selection and recommendation of appropriate surveillance interval are crucial after colonoscopy. Endoscopists must integrate finding from colonoscopy report, the associated pathology report, relevant clinical features, and surveillance guidelines to prescribe the surveillance interval. Provider factors such as low confidence about the colonoscopy quality and the lack of knowledge of surveillance interval, in addition to the patient factors, the age, the comorbidity, and the poor bowel preparation. The colonoscopy report, which is very important to fulfill this point, is indication for the procedure, depth of intubation to the cecum or to the terminal ileum, incomplete, and the reason for incomplete examination, withdrawal time, the Boston bowel preparation scale, polypectomy performed, cancer detection, and complication. This is a paper in Egypt with Dr. Hayam Fathy about the multi-center study about the quality indicators for colonoscopy in Egypt. This is the patient and the methods about the indications of colonoscopy, pre-procedure, clinical assessment, obtaining written informed consent, adequate colon preparation, sedation, cecal intubation rate, withdrawal time, adenoma detection rate, complication rate, photographic documentation, automated sterilization, regular infection check, and well-occupied pre-procedure recovery room. We have 1,000 patients in this study, and the result in conclusion, in Egypt, we can say that colonoscopy practice in Egypt, including high cecal intubation rate and low complication rates, but we still have adenoma detection rate, bowel cleaning quality, and infection control measures should be improved. In conclusion, this is again to the guidelines. This is all the KPIs collected in this figure: pre-procedure, intra-procedure, and post-procedure. And thank you.